You appeared. Good morning.
Magic.
It like beyond magic. Not
Yeah.
even a word for it. It's
Yeah.
amazing. It's nice to see you, Dr. R.
You too, Carolyn.
Thank you. Thank you so much. Well, we have our questions and we're going to get started with them. And I see you have your coffee. I have mine too, meaning my cat can't jump on my coffee. So we're going to try and keep that. Hi, Kathy. Good morning. And a premature good morning to everybody who's going to come up. We're going to start off with the question that we left off with last Thursday. And I hope you had a great weekend. And everybody. So, okay. This question comes in from a lot of different women, but this particular woman is the question that I'm going to present. She says, I'm in my 70s, never took hormones, as all doctors told me to stop. Nope, 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 once I started. So I know I need to start them as I feel horrible. And I have now many years. My doctors tell me I'm too old and that hormones at my age are going to be very dangerous due to my age. I found this incredible group by chance, and now I feel some hope. Is it true there might be help even for me at 70, not ever having taken hormones? I want to feel well and not old and fat and just miserable. All I do is cry. And if there is help, then wow, please, can you tell me how to do? I'm a young 70, but I feel 150 in every way. Youch.
I mean, it's a major question, and it's so important.
I know.
And the answer is all the information you have had from whomever you've had it, dear questioner, try and erase it. And let's start from scratch. From brand new, you're 70 years old, you're starting to wonder whether replenishment can make a difference for you. There's a couple answers. Highly likely it can make a difference for you. And it's great to start whenever you can figure it out. Whenever it comes to you. I started treating my mother when she was 86. Why did I wait so long? Because she wouldn't dream of having me be anything to do with female doctor, her son. Back in the day, this was a different generational value system, and I love my mother tremendously. But my first opportunity came when she was 86, and the replenishing the hormones had advantage to her. And my dear precious mother-in-law, who I felt so much love for, she's neither my mother or my mother-in-law are on earth anymore. This was a while ago. My mother-in-law, we started replenishing her hormones when she was in her late 80s. And to tremendous advantage to both. My mother-in-law was really dramatic. The recovery of some of her functions that she had was just truly dramatic. Now, how we like to address the situation is that whenever it comes to you that maybe you should consider hormones, we then customize, individualize the whole process for you. And there are some caveats if you haven't had hormones from right when you started menopause. But before I go to those caveats, I'd like to elaborate on why it's so easy to go to any healthcare professional, your doctor, your gynecologist, still to this very day, and receive some intense information like you should not be taking hormones. How in the heck did that happen? And for those of you who've been listening to our Facebook Live, Carolyn and I have only discussed this about 3,000 times. I think the ticker talk is up to 3,892.8 times that we've.
No, it's 0.10, like 10 years, zillion, gazillion exponentially.
Yeah, that's a lot. In other words,
it is.
That's what you're trying to say. The gazillion exponentially sort of implies we're talking about a big number there.
Yes, it's high. What you gonna do?
Well, this colossally challenging thing to understand occurred in the whole world of women's health. Women and men have been taking hormones only for about 1,000 years, because people thought about it 1,000 years ago and developed methods of delivering hormones to some of the elderly. And then in the 50s and 60s, the pharmaceutical industry came up with an ability to mass produce hormones for women. And the pharmaceutical medications that they did produce, Premarin and Prempro, became the world's best-selling and most profitable drug that ever was. And in fact, by 2002, there was 18 million American women taking one of these two hormone replenishment medications. That was 40% of all American women in menopause. And then came this colossal explosion of wrong information that the press got a hold of, the report of a study called the Women's Health Initiative, published in 2002 in the Journal of American Medical Association. And the results were misinterpreted, and the study was reported out in an inappropriate way. And for one arm of the study, the horse urine-derived estrogens alone, there was a reduced risk discovered. That means women who were treated with Premarin alone were at less risk for breast cancer, heart attack, and stroke than women who were untreated. But there was this mini inappropriate blip in the Prempro arm. That's Premarin plus this medroxyprogesterone acetate. Progestin, yeah, it's a challenging molecule. In the study, they found that there was a 1.26 relative risk. That is a tiny, tiny statistical analysis of increased risk. But as they reported in the original study, 1.26 is not statistically significant. But who read the fine print except physicians like myself and many, many others, and pharmacists and many, many others read the fine print? The fine print said this was statistically insignificant. In scientific terms, what that means, it didn't have any merit whatsoever. There was no increased risk. However, that's not what the press got a hold of. And part of the reason they got a hold of it, it was promoted by one of the maverick members of the original study committee who had something misogynistic going on in him, as far as I can give you an editorial opinion, because he was dead set against hormones no matter what the data showed.
Yeah.
They blasted and printed that out, and the American female public, then the world female public, and the American and then the world healthcare providers who could write prescriptions for these hormones got absolutely terrified. And all that they could think about was that hormones increase the risk of breast cancer. And that's what everybody learned. That's how that was misinterpreted. And it exploded out in the public like nothing I've ever observed in my 50 plus years of being a physician. No piece of information, maybe the misuse of cortisol and the overprescription of cortisol, got similar press in the medical world, but not in the public. But this went wild. And so the poisoning took place to women all over the planet and to healthcare providers. I say poisoning because the information was wrong. When I originally read the study, I saw that it was wrong, as did many of my colleagues. It was a wrong interpretation. It was statistically insignificant. By 2006, because the study committee was continuing to follow up on these women, they knew that the relative risk had reduced to 1, which means there was no increased risk.
Right.
So we knew that by 2006. The European literature had already told me that compounded bioidentical hormones had reduced risk. So I never dropped a beat in treating. And then in, I think it was 2016 or 2017, the original Women's Health Initiative study group published in the original journal a retraction. They said this, I'm quoting from their published study. After 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke in women taking Premarin or Prempro. How many folks out there have heard of that retraction? Very few. Very few physicians. Because I instruct physicians, and because I'm part of a large coalition of physicians, and because I talk to so many patients, very few doctors have been understand that original study was wrong right out of the gate, what they published, and that attraction recurred. And that actually, and this is what I want you to hear, women treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. That's what you need to hear. And all that stuff about age, well, maybe you should take your hormones for just a few years and for the smallest amount. That was not true either. That was just some made up intuitive belief about hormones. And yes, the daughter of the mother-in-law I spoke about is with us today. Oh yes, I get chills and tears when I think of my beloved mother-in-law.
Yeah.
And my dear friend. So this you can start hormones at any age. That's why I said I started all this off by saying, yeah, I treated my mother and my mother-in-law when they were in their late 80s. Now there is some thoughts here, and sometimes our intake process of any potential patient includes a very extensive questionnaire, and we get to learn about their health story, including any special risks they may have. And when they have a special risk for coronary arteriosclerosis, as actually all women do who don't have estrogen for 10 years, 10 years into menopause, that's the general number that's tossed out there, that estrogen is so protective to arteries that you can wind up having arteriosclerosis. So we pay attention to that. And if we think that there's a possibility of diminished circulation to the heart muscle because of arteriosclerosis in a coronary artery, prior to treating any woman, we get a cardiology consult. Or we'll go right ahead and order a stress ultrasound, a wonderful procedure that's non-invasive and will tell us if there's any kind of diminished circulation to a woman's heart muscle. If there is a clot discovered in her coronary artery, that clot needs to be dealt with before we give you any estrogens because of this 1 year obscure phenomena. Oh yes, I'm going to mention it. There's 1 year of vulnerability there for a woman who actually has a clot in her coronary artery, that clot will break loose and cause a heart attack. So we know about all that, and we address it in the menopause method. And any savvy physician or nurse practitioner or prescribing pharmacist that specializing in treating women in menopause is going to have heard of this. In fact, that's a criteria you can use. So it's just like anything else in medicine. It's step by step by step. Oh, you want to take hormones? Let's listen to your whole story and do what we need to do to clear the deck for you to take them for your whole life.
Whole life.
Whole life. Right up to the last day, as I am doing. I'm hoping I'm not seeing my last day.
I was just going to say, it's about like 100 years away, so just keep taking.
I hope so. So long as I'm walking and talking and thinking, I will be taking my testosterone and the other things I'm doing for andropause. Now, yeah, your job, questioner, is the same as every job that every woman faces. Find someone who really knows what they're doing and are taking on specializing in treating women in menopause. And you connect up with one of those. Of course, we love our system the best on the planet Earth. If I don't mind saying, the menopause method. Find someone, connect with us, and we'll connect you with one of our providers if we have one in the state you're in. And this is part of a routine ritual that we do, is we evaluate our patients and follow the bouncing ball down any of the various risk factors that they may have and do the right thing. Now, having said this, I was talking to one of the most knowledgeable prescribers, advisors, a compounding pharmacist who advises many physicians outside of Dallas, Texas. If you're on, Jim, you know who you are.
And it's a great interview to watch, but I got to tell you, yes, that
Jim Hertzern. And he and I were talking because knowledge of this coronary risk and what's called the window of opportunity is fairly recent in onset. And we thought of the 20 plus 30 years that we've been treating women in menopause that we didn't know about this. And we've treated hundreds and hundreds and hundreds of women in menopause, and there's never been a problem, including women who had way, way too much weight on board for their health because they're at special risk, and including women who had insulin resistance or diabetes because they're at special risk. Well, we weren't screening out these women because we weren't aware of this rare situation of a possible clot in the coronary arteries. And so we never had an event. So it just gives you an idea.
Right.
So back to the questioner, it's a lovely day in the neighborhood to start hormones, and your only job is to find yourself a specialist who knows what to do, and including address that 10 years plus that you have not taken hormones and the possible fallout of that and how to deal with that properly medically. It's like anything else. It's due diligence. Figure it out and do it.
It is due diligence. And so you would not have a problem then in saying that someone who is 68 years old or 69 or 70 or 75 can
or 85.
85, 90 even. You have a patient who's 79 years old, am I correct?
Oh, yeah. I've been working with her for almost 20 years.
Right.
She's, still having intercourse. She's still playing golf. Her goal for this year, as I've mentioned before, is to get 10 more yards out of her drive.
I love that. And then, you see Dr. Berkson, and I got to tell you, that's a mind blower. And she's amazing. And as we've discussed before, it's very easy to be able to tell man or woman who is or who is not on hormones.
Yeah.
This is a hard one for me because I see this a lot. And
you can see it everywhere we go.
Right. Well, that's a good answer. And I'm hoping, I know we're going to revisit this again, because women are very, very scared. And I understand that, I do. But
tremendous misinformation. It's led to the misinformation has made it to the highest decision makers in the United States, who are, one of their responses, they're using that information to eliminate access of American women and men to compounded bioidentical hormones. So this is a big deal, and we invite you to go to wethewomen.us.
Oh, okay.
Maybe you would post that.
Yeah, I sure will. I didn't know it was that.
It's wethewomen.us.
You got it. I'll put it on the CBHRT page.
Right. And then also go to the professional website, cbhrtcoalition.org. Those are unusual, .us and .org. And you can join, hopefully, millions of American women so that we can inform our representatives in Washington that we want access to these compounded bioidentical hormones. That is very, very important. And so, yeah.
Oh, yeah. Thank you.
I'm not just mentioning this as a side thing.
Right.
Bioidentical hormones could disappear with the current approach of the pharmaceutical industry, the FDA, and the National Academy of Science. And
I'm going to go ahead.
It's a wrong thing to do, because the individualization you need, the estriol you need, the testosterone you need compounded bioidentical hormones. Let me repeat, the individualization, women vary enormously, woman to woman, as to how much of each of these hormones you need, how well you absorb them, how to individualize it for your particular body, which is different from every other woman on earth. No big work, no concern. We just individualize it patient by patient by patient. And that's how we address it. You can only do that with compounded bioidentical hormones.
This is so important.
The number of variations in prescriptions is infinite. No problem for someone who knows how to figure it out. But you can't do this through pharmaceutically manufactured drugs. You can do that with other pharmaceutical manufactured drugs. Bless their hearts. It's amazing. There's all kinds of therapies that you don't have to individualize to that degree, but not hormones. No, hormones are way too powerful. You want to get it right. And then the access to estriol. There's no manufactured product out there that includes estriol along with estradiol. This is very important. And then the topical method of delivery matters to me, matters to a lot of women. When you get some of these hormones that are produced in pump bottles or Topiclix or anything, what you're really purchasing is 99% of what's in that jar, that Topiclix or that pump bottle, is something called the base, what the hormones carried in. And these are strong solvents. And you're going to be applying about a quart, plus or minus, of solvent every year for 10, 20, 30, 40, hopefully 50 years. Quart a year. Well, my background is I was a holistic physician right out of the gate before there was a name for that. And one of the things that gives people trouble is toxicity. And what gives people trouble? The dinosaurs. You are still being haunted by dinosaurs. They're not biting you as once we're... do you remember, Carolyn, when we were in danger from walking down the tundra and getting bit by a dinosaur?
Yes, when we first met.
Yes, exactly. I remember it very clearly. We met and we were saying hello. A dinosaur popped out behind the bush and we had to run. Holy mackerel. Fortunately, we were very fast and we did run away. Well, the dinosaurs are still out there haunting us.
They are indeed.
Because a lot of the solvents comes from oil, gasoline type stuff, and you're applying something of that order, not as smelly as gasoline, but it's still a strong solvent if you're taking these topical manufactured products that are in gels and stuff, and even compounded stuff. So a lot of moving parts here, and I don't want to make anyone feel overwhelmed. You have only one job as a woman. There's only one thing you need to do, is you need to go shopping until you meet up with and trust a healthcare provider who can prescribe hormones. We're talking about a physician or a nurse practitioner or a licensed prescribing compounding pharmacist or a PA. You got to find someone who knows what they're doing and that you can trust. That's what you got to do.
Right, who has a
That's your
serious
job.
passion.
You don't have to know all these details. Every
Right.
physician that we train and mentor, we're telling them all these details. Every nurse practitioner, every PA, every prescribing compounding pharmacist. So you don't have to know all these details. You have only one job: go out and find someone that you like and you trust. They're making a lot of sense, or inquire about the menopause method. With all non-humility and humbleness, we're the top of the mountain.
I think so, for sure.
I think so.
Yeah, 3 years in, and I got to tell you, I am sitting here and I'm happy and I'm smiling. I'm in school and doing things and working and doing this and whatever. And I have to attribute that to one thing. And I'm very, very grateful. And I know that many other women are. So thank you so much.
Before you go on, don't you think it's amazing that instead of out there on the tundra having to dodge dinosaurs, Carolyn, nowadays we're talking on these computers and on screens. No dinosaurs in sight, I don't think. Although I just heard a sound outside that I am a little concerned about.
No, dinosaurs don't moo. I think only cows do.
Okay, thank you. Thank you. That's probably a cow then. Might not be a dinosaur.
However, I grew up with dinosaurs and in Encino, California, of all things. And it was back in the day when my father had an actual exchange that he answered the phone calls, So things have changed, but those dinosaurs, they're stubborn.
Yeah, they're still hanging in there.
They are indeed.
In your hormones.
My dear Dr. Rosensweet, you know all about that, and it's pretty amazing. And I'm glad we met like 6 million years ago. It was incredible. And now are still alive and can connect on Zoom and have these wonderful women. Welcome, everybody. I see your questions. We will get to them. That I can guarantee you. So, moving on to question number 2, which I think you might enjoy. Where the heck did it go? Oh, is it smart to start off with estrogen and progesterone, testosterone and DHEA first, or treat adrenals and thyroid first, or do both? This is very confusing.
Yeah. Well, I'm going to turn on this new invention that I've made that I call the Unconfusinator.
The Unconfusinator?
Yeah, and I'm going to press the Unconfusinator's button right now. My God, and it's going to straighten the whole thing out.
Okay.
When a woman goes into menopause, one of the things that we say to all of our physicians and nurse practitioners and PAs that we train is treat the menopause first, see what's left.
Oh.
For example, a lot of diminished adrenal output of some crucial hormones will recover if all you do is replenish the ovarian hormones. Right out of the gate in our method, and there's many functional medicine providers, healthcare providers that do the exact same thing. We're checking out your thyroid because midlife, men and women, a lot of folks low in thyroid as well. We don't drop a beat in implementing replenishing the ovarian hormones. We do that right out of the gate. If a woman hasn't had a period for 6 months or a year or 2 years, or even if she's in the perimenopause, we're going to start up those hormones right away. We're not going to slow down anything to evaluate the adrenals or the thyroid. We are going to start up those ovarian hormones on the first visit. And at the same time, if the woman has not had some very specific testing for the health of her thyroid gland, well, we're going to learn about the health of her thyroid gland from our intake questionnaire, which is very designed to pick up a lot of stuff, and especially low thyroid, because it's so prevalent. because people have overstrained our thyroid glands. We've demanded too much. So when we're young, they keep up with our increased demands, and then after a while, they get a little tired. They don't keep up. So a lot of people are a little low on thyroid. So right out of the gate, if they don't show up with the specific thyroid test, we send, I'm going to sneeze. Excuse me.
A huge collective. God bless you.
Thank you.
You're welcome.
We're going to test that thyroid, and when we get the blood test results back, along with what we've learned from the woman's history, we'll begin thyroid if we need to. We won't delay that. But the very first visit in the menopause method, a woman is starting her hormones, her ovarian hormones. Now, there are some very rare cases that the adrenals are so exhausted and the thyroid is so exhausted and the corticosteroid output is so low, or the thyroid hormone is so low, is that we got to get on that bandwagon really early on. It won't slow us down from replenishing the ovarian hormones, but one of the ways that we learn about that level of adrenal issues is through that initial questionnaire and through the initial testing we do. Now, the most common thing we run into in adults midlife, non-20-year-old, non-youthful levels of adrenal and thyroid output. No, they've been too heavily demanded upon, and so many adults come in with minor or moderate compromise to thyroid and adrenal. Now, here's the interesting thing. For those of you who are major biochemistry fanatics, or, you know, you love
Don't freeze. You're back. Uh-oh, you're gone again. Oy.
Yeah, are we back, or we lost it?
No, we're back. Sort of, kind of. Just keep talking.
Those of you who are biochemistry aficionados, if you look up ovarian steroid biochemistry, you're going to learn something, that there's a lot of interconnections there. And the ovaries rely on the same raw materials to produce estrogen, testosterone, DHEA, progesterone, and cortisol. And if you are just way too stressed and your tools to deal with the stress are not excellent, you're going to trigger the biology of the stress response, and you're going to wear down this major stress hormone output called cortisol and adrenaline. You're going to wear them down. The great news is that all you have to do is replenish the 4 ovarian hormones in menopausal women, and what we will observe is the recovery of the adrenal corticosteroids.
It's a nice thing.
They recover, and you do not have to treat with cortisol. Do I treat with cortisol? Yeah, less than 1 in 100 patients. That they've exhausted that corticosteroid production so low that we want to address it. And we'll get clues about that level of exhaustion from the initial questionnaire, and we'll do some testing and we'll see it. But it's very rare, though I see a tremendous amount of minor to moderate depletion of the corticosteroids that always bounces back merely by replenishing the estrogen, progesterone, testosterone, and DHEA.
It's fascinating.
As the body no longer needs to produce all of those hormones. And so it shunts the available resources back to the production of the corticosteroids, which is highly favored anyway.
Right. So it's sort of like in doing so, it's compensating for.
Yeah, it's going to spread the resources.
Spread the resources.
To produce all of the ovarian hormones, And when the ovarian hormone, plus the corticosteroids, and so when the ovarian hormones disappear, well, one thing that happens is the ovarian hormones, estrogen and testosterone especially, are recruited for the biology of the stress response. You know, you think of adrenaline and cortisol at the vanguard, yeah, but they're not the only ones. So you can deplete your corticosteroids by no longer having the ability to provide estrogen and testosterone to the biology of the stress response. So the body has to emphasize the corticosteroids.
Right.
And this, I hope this isn't confusing to people. When you replenish the estrogen and testosterone, the corticosteroids will bounce back all on their own, 99% of the time. And we always pick up on it. We always do 24-hour urine hormone testing anywhere between 3 and 5 months out. And if there's low corticosteroids at that time, we'll make a decision about whether to actually treat with cortisol or not. Because given a year, the corticosteroids will bounce back. Just
Right. Uh-oh.
no, no, we consider all of it. We consider the ovarian hormones, the thyroid, and the adrenal. In fact, it always happens in the first visit. And
Oh, Dr. R, you're frozen.
too, and if we need to do some adjustments there, we will. And having to add some thyroid treatment is common, and having to replenish corticosteroids, very uncommon, way less than 1% in my practice.
Got it. And I know you've had a good practice. Thank you for that. Thank you for that. A question just came up. I'm not going to get to it right this second, but I will. I'm going to go ahead. Thank you for that answer. Indeed. I have a woman who said that she just got her results from her saliva test and also this other kind of test. I think you refer to it as like a 5-point urine something or another. Not sure what test that is exactly. Nevertheless, she says, how is it that I am postmenopausal 6 years? I'm 57. She's taken testosterone, DHA, and progesterone only. However, these two tests revealed to her that she is producing a good amount of estradiol, and she wants to know how that can be. Is that like normal, possible?
Well, let me start with the testing. As I've said many times, I am a non-advocate. I advise against the urine 5-point test. That's when you pee on the filter paper 5 times. And I am advised against, with all due respect, using saliva to test hormones. And 5 years out in menopause, I can't think of a reason in the world to test prior to treatment.
Right.
I have done that. I have done the 24-hour urine hormone test on women who haven't had a period for a year or 5 years. But very early on, I learned, oh, guess what? They have extremely low estrogen, progesterone, testosterone, and DHEA. Now, there are some women, so why test? To find out that it's low. Why spend the money? Because you're going to be super low, and the job is going to, and I've never seen an exception. Now, there are some minor exceptions possible. Women who have increased adipose tissue. Adipose tissue, I'm shy to mention this because I know it's a tender topic. But overweight, excessive fat cells in their body. they have the ability to take, I'm not saying that the questioner does, but I'm suspecting that she does, because the adrenal glands continue to produce some androgens, testosterone and DHEA, even when the ovaries, which in a woman are the principal source of the output of testosterone, and the ovaries go to, they're done. I think this questioner was several years out from her last.
Yeah. Yeah. Well, 6 years.
6 years. Yeah, her ovaries are producing 0.
Right.
However, the adrenals can still produce some androgens, do. And a woman who has an abundant amount or an excessive amount of adipose tissue, in the adipose tissue, can convert the adrenal produced testosterone into estradiol, which accounts for the following. Number one, there's a significant number of overweight women who do not complain of stressful menopause symptoms. They're not getting the hot flashes. They're looking around and they're going, what's everyone complaining about?
Yeah.
Fine. Because they are producing a sufficient amount of estrogen. Not enough to produce a period. No way. They're not even getting close to that. But enough that if you do testing, you're going to see some estrogen there. But what I assert, and we're very, very specific about this, we know what we consider to be too much estrogen and too little estrogen. We publish this on the 24-hour urine lab report that we do with the 24-hour urine lab that we work with. And a woman can have too little estrogen, and I'm going to assert that the questioner does not have enough estrogen to protect her bones and vagina. So she could ask herself, if she's having intercourse, is she having pain on intercourse? Or is she having to use a lubrication when she's having intercourse? If she's not having intercourse, it's a little tougher to tell the health of the vagina, because if you don't have a certain amount of estrogen, you're going to get symptoms of estrogen deficiency, and one that's going to show up that's for those who are having intercourse is the health of the vagina. So, I'm going to make a wild assumption that the questioner has some additional weight on her and is producing sufficient estrogen, enough to register on the testing, but not necessarily enough to protect the brain, the bone, the vagina, the arteries, the skin.
Right.
So don't rest on your laurels or that testing. Go to someone who has gotten so much into treating women and hormones that they found their way to the 24-hour urine hormone test. Why don't more people find their way to the 24-hour urine hormone test? Because the number of factors of hormones and metabolites that show up on a 24-hour urine hormone test is a bit staggering. And when I first saw my first report, I had never seen so many things show up on a report. And it was daunting. I had a whole new mountain to climb called learning how to interpret 24-hour urine hormone tests. But I had friends who loved it, and I very quickly saw how critical it was to understanding what's going on in a woman I'm treating. So I embraced the new learning experience, and it took me maybe 100 tests before I got good at it. Unfortunately, the laboratories, they help you with the interpretation. That's what I did. I kept calling the lab on every single test result I had to get one of their interpreters to teach me about 24-hour urine hormone testing. They gladly did that. And then there came a time I didn't have to call them anymore because I had learned enough. So yeah, it's a whole new mountain to climb, but it's so phenomenal to have 24-hour urine hormone test results, because you can see what's going on in a woman that you're treating. And I'm going to say to the questioner, you might have Richter scale registering, I'm just kidding about the Richter scale, this isn't an earthquake, Richter scale registering estrogen, but I would assert that it is not enough for the long haul for your bones, your vagina, your brain, your arteries. It's very unlikely that you're producing enough or that you will continue to produce enough from the conversion of testosterone produced in the adrenal gland in your fat cells. So, moral of the story, get the same job. It's always the same thing. It always comes down to the same thing. Find someone who's really choosing to specialize in the treating women of menopause with bioidentical hormones. And it's one of the criteria you can use. I suggest to women they call an office. Does your provider do 24-hour urine hormone testing? Well, you're not going to get a lot of yeses, but it can be one of the criteria because almost invariably, when you find a healthcare prescriber, provider, a physician, a nurse practitioner, a PA, or a prescribing compounding pharmacist that is doing the 24-hour urine test, it's a written guarantee that they are major aficionados.
Absolutely.
Of getting it right. And they're fascinated by it. And they took on the learning curve. And so it's one of the criteria we suggest that you use when you're going out shopping. Talk to the office personnel. Does your physician actually test women in menopause with 24-hour urine hormone testing? If the answer is no, it doesn't totally eliminate that provider, but it does tell you a lot about them. They just haven't taken this particular field on with the level of rigor and vigor it takes to get great at it. Doesn't mean they can't do you some good. They can. I mean, God, women who are on Prempro, they saw their physicians once a year, 10-minute visit. Here's your Prempro, or here's your Premarin. And you know what? Those women did well. They were grateful, and they did get some support. They didn't get the kind of support, and they didn't have the androgens, so important. Testosterone, so important. But a lot of good was done by those particular pharmaceutical medications. A lot of good was done by collecting the urine of young women and young men and distributing it to the elder men and drying it out. And back the Chinese were doing that 1,000 years ago.
Right, the life force.
Yes, which was about 199,000 years prior to when we met up on the tundra dodging dinosaurs.
That's right. The aristocracy.
So there wasn't much going on back when we first met up around this.
No, it's pretty dry. Walking around. So, yeah, calling a doctor's office and saying, excuse me, but do you do the 24-hour urine? That's an interesting.
Well, you can start with a different question. I'm in menopause and I'm interested in getting compounded bioidentical hormones. Does your physician prescribe them?
Got it.
That's your first question. And then ask, does your physician use the 24-hour urine hormone test to assess what's going on in my body?
Okay.
And yeah, there's only 3 questions. Does your physician treat women in menopause with compounded bioidentical hormones?
And then you can say thank you very much.
That's right. And you can say thank you very much. Exactly.
Either or. No. Don't be mean. Just thank you very much.
That's right.
Right?
Exactly.
It'll save you a lot of trouble. Oh man. So yeah. Is there such a thing? Get this one a lot. And I asked it a lot. Is there such a thing as ideal levels for estrogen and progesterone? And if so, could you let us know what they are?
The answer is yes. Let's take estrogen, for example. From my understanding of the medical literature and my working with women, it's possible to give a woman too much estrogen. It's also possible to give a woman too little. And the common way to approach treating with hormones is this. A woman's having symptoms like hot flashes. You start on a low dose of estrogen and you gradually increase that dose, and lo and behold, the hot flashes go away. And women say, I feel so much better. Or you keep on increasing the dose and the woman feels even better. And then she develops symptoms of estrogen overdose, like breast tenderness. So the provider suggests to the woman that she lower the dose. And this is the common way that dosage is being done in the world of compounded bioidentical hormones, and also in the traditional world sometimes. It's called dose determination by symptom alleviation titration.
May I interrupt really quickly? There is a book. You can download it free called Happy Healthy Hormones. And I say this all the time because these 2 pages are amazing. 326 and 327 will help you with that dose determination. There you go. Okay.
And then it's even advised by the traditional North American Menopause Society and the American College of Endocrinology that method be used to determine dosages for women in menopause. And they advise against testing, those 2 societies. And there's reasons why they advise against testing, because there's problems with blood testing called pharmacokinetics. When did you take the last dose? As opposed to when you drew the blood. I'm not going to elaborate on that. And they're very much against saliva testing, as am I. So, but they don't know about 24-hour urine hormone testing, so that's why they're advising don't test. They're saying rely on symptom alleviation. However, prior to doing an annual seminar that a wonderful doctor and I did at a very large functional medicine conference, we were given a whole day. Every year before I went, I would like to see, well, what have I learned new in this year? So I can tell the doctors, et cetera, who were attending there. And one year, what I decided to do was review my preceding 24-hour urine hormone testing on women who said to me, wow, I'm feeling so much better. That's the clue. That's the time we want to test them.
Right.
And so we tested them. They had determined their optimal dosage based on symptom alleviation. And that's when we test them. It's usually between 3 and 5 months of getting treated that we test them. And to my utter shock, 25% of the women that said they felt great and didn't have breast tenderness, for example, were on dosages of estrogen that for the long haul I would consider excessive and put their breast glandular tissue at risk of proliferation. Don't want to do that. And 50% of them, although they said they were feeling good, they thought they were on the right dose, were on insufficient estrogen to protect their vagina and their bones. We know those numbers. The laboratory we use publishes those numbers on their menopause method report form. You can get too much or too little. Are there exceptions to too much? Yes, there are. They're rare. There's some women who really need supercharged, robust doses of estrogen to bring back their mind, to address their cognitive challenge. A lot of women get wonderful results for improving their cognition on the standard dosages that are defined on that laboratory report. But some women, it's uncommon. Some women, we really got to jack up those estrogen doses because it takes that to get their brain function back. Rare. And then everything's risk benefit. So just because they're on high doses of estrogen doesn't mean they're at risk for breast cancer. Oh, yeah, estrogen does not cause breast cancer. There are plenty of causes of breast cancer, but Estrogen is not one of them. And in men, testosterone is not something that causes prostate cancer. So I know I'm veering off in a couple different directions. The moral of the story is testing really matters, and the common way to approach, is there too much or too little, is by symptom alleviation, and it won't get you everywhere you need to go.
Right.
So at the 3 to 5 month mark, we test every woman who says, gosh, I feel better now. And very often, 75% of the time, we're doing some minor tweaking of the dosages, and then they go for a year before we test them again. We don't even have to retest them because they're not spot on. They don't have enough, or they have a little bit too much. So yes, those numbers are known, and we care about those numbers greatly. And everyone trained in the menopause method, that's one of the first things they're introduced to. What's the proper amount? What's not too much and what's not too little?
Right. I think that women want an actual number like 55 or 2010 or
well,
I'm just throwing
I'll give you the number. I'll give you the number. Now, as far as a woman who's being treated, I'm going to cut right to the chase. The only way to get super accurate results, not the only way to get information, blood tests can give you a certain amount of information, but the only way to get super accurate result is to do the 24-hour urine hormone test. And the range for the potent estrogens, there's the ones we care the most about. That would be estrone plus estradiol. These are the ones that can overstimulate breast glandular tissue, or if you don't have enough of them, you're not going to protect your bones or your vagina. The range, the optimal range, is somewhere between 8 micrograms and 24 micrograms per 24 hours. I'm sorry, the optimal is between 8 and 14 micrograms per 24 hours. When you add up the 24-hour excretion of estradiol and estrone, they should add up to somewhere between 8 and 14 micrograms per excretion per 24 hours. 8 to 14. There's your number, but you're going to have to determine that on 24-hour urine hormone testing. And if you are excreting between 8 and 14 micrograms of the sum of estradiol plus estrone in the urine, you're in the optimal zone. 8 to 14, there you go.
Got it. Well, thank you. Thank you very much for that. For me, I think that I would have to leave that to my expert professional mathematician.
Absolutely.
Yeah, because
I used to fix my own cars.
Right.
I love them, and I even went so far as to rebuild a Corvair van engine.
Right.
And by God, that engine ran when I finished with it. It ran, and we went out west with it, and it actually ran 7,000 miles before it froze up.
Yes.
It became a permanent playground feature. And what I learned was, when I wanted to rebuild my Volkswagen engine, I went to someone who was specializing in rebuilding Volkswagen engines, and he let me watch him do it. And oh my God, I saw how many different things that he did and the level of care he had. And I said, no wonder that thing only ran 7,000 miles. And it's not a lot different from menopause. To get it right, you want to, it's like if you want to have an appendectomy, as my son points out. Well, I could do an appendectomy. I was trained in medical school, and I actually sat in and was an assisted surgeon on an appendectomy. I could do it. But I'm the last human being in the medical field that you want to do an appendectomy. If you need an appendectomy, you want to do someone who's done 8 of them that week and hundreds of them prior.
Right.
They're going to be the ones who are good. They're the ones who are specializing it. They've had a 3-year surgery residency beyond internship, minimal. They are trained and mentored into how to do it. That's who you want, or someone to set your bones. You don't want me to set a forearm. You could wind up with a deleterious result. You want an orthopedic surgeon who's had many years of residency, specialty training beyond their surgery residency in orthopedics, and they're mentored all along the way. Well, I'm suggesting that hormones are extremely powerful, and to get them right, you want someone who's properly trained, mentored, and specializing. In fact, that's what I spend the majority of my time doing, is training and mentoring physicians and nurse practitioners on how to specialize in treating women and hormones. Now, they're going to be the ones, like you were saying, Carolyn, who understand the numbers. And you want to rely on them. Just like I no longer, when my car recently needed $3,000 worth of repairs. It had 106,000 miles on it, and oh my.
Yeah,
well, I took it into the dealer and I said, please fix it. And when they were all done in my car, I drove away. I didn't want to know every single detail of what they had found and did. I didn't want to stand over them and watch them do it. They knew how to do it. That was their specialty.
They were stitching it up. You said, thank you.
Oh my goodness. Look what happened to the time. It happened again, Carolyn Shapiro.
Weirdest thing, and I don't know how that happens, but it does. I've gotten some really interesting questions. I always get fabulous answers from you. So I always thank you from the bottom of my heart. And I thank all the people that come up. We'll get to the questions. I will write back to you too. And we'll just keep it moving. So for today, you know, happy. And we'll all just keep it moving, and we'll see you again on Thursday. And we're just going to continue this, right?
Right on, Carolyn. Good to see you as always.
Good to see you too, Dr. R. And for everybody, enjoy. And we'll see you on Thursday morning.
Bye-bye.
Bye.